So, my name is Dr Rinky Agarwal. Today I will present a case of unexpected diagnosis of choroidal mass, which gave us a sigh of relief. Okay, so the 44-year-old female presented to us with diminution of vision in right eye for 2 years, and it was worsening since 1 year. First of all, she did not have any other significant history, or systemically she was absolutely fine. On ocular findings, she noted dilated blood vessels or infratemporal iris with pigmented mass involving ciliary body, causing an anterior iris bulge. She also had irregular pupil and NS2 with diffuse PSC. Infratemporal lens coloboma was noted. Her vision was 1/60, while other eye was absolutely normal. So you can see over here, there was a mass lesion noted in the inferior temporal quadrant, and it had some dilated blood vessels along with causing pushing effect on the lens, that is lens coloboma inferiorly. So we made a diagnosis, provisional diagnosis of pigmented ciliary body tumor, choroidal melanoma, and then we performed a B-scan USG where we could appreciate a solid mass lesion with medium internal reflectivity in the anterior course of fiber, which was extending till crystal lens, measuring 11 into 8.4 millimeters. Then even color Doppler appreciated there is central and peripheral vascularity within the tumor mass. MRI also on MRI we could appreciate the hypointense lesion on T2 and isointense to hyperintense on T1. It was quite limited. There was no encroachment on the ciliary on the other tissues of the eyeball or surrounding structures. Whole body PET scan was done because we were suspecting choroidal melanoma. It showed only the FDG uptake in the lesion with no other metastasis. So we made a diagnosis of ciliary body melanoma, and as the tumor mass was more than 0.8 cm³ with low visual acuity, we recommended radical surgical surgery, enucleation along with histopathological examination. So after enucleation, after we saw the result, it showed a tumor in the ciliary body, and it showed bundles of fusiform slender spindle-shaped cells with the cytoplasm, which was suggestive of leiomyoma rather than a choroidal melanoma. So pigmented ciliary body tumors can be multiple, they can be malignant or benign, and malignant as most commonly ciliary body melanoma is there. While in benign you have multiple other ones, in that post-traumatic iris cyst and leiomyomas are quite rare. So we can see that leiomyomas and melanomas almost, even though we describe array of differences between them clinically as well as on USG or MRI or PET scan, they are clinically impossible to differentiate these tumors, and that's why the very first approach towards these tumors, which if they are large, is enucleation. Other treatment tumor modalities like localized excisions, partial thickness scleral flap creation, and then excising the tumor, sending it for diagnostic biopsy, and then taking a step if it is positive. They are also described, observations also described, but our patient, when we gave up all the options to the patient, that observation, then we can also go for diagnostic biopsy or FNAC, and then or else radiation. The patient actually chose melanoma because she was traumatic, she was just mentally traumatized by the name of a cancer. Okay, so she did not want any she did not want to take any second chance, and that's why she chose enucleation. So in these cases, whenever you do an enucleation, histopathological examination saves your day, and that's why it is very important to have a collaboration with a very good histopathological setup who can actually provide more accurate results. This may take around 10 to 12 days for the results to come, and there can be multiple other things involved like immunohistochemical study was done for our patients. So all those facilities should also be available with the histopathological centers. So why was it a relief? Because our patient was mentally traumatized by the name of cancer. She was just scared because she had her kids to take care of, her family to take care of. So the moment we revealed the news to her that it is not a cancer and it is a benign tumor, she had such a psychic relief that she doesn't have to live in that fear. So sometimes it is the fear that kills the patient more than the disease itself. So even though we told her that it is a tumor which is benign, we would like to conduct yearly PET scan for 1 or 2 years to see whether there are any recurrences. So that's why we are still being cautious. Now after 1 year of follow-up, she does not have any recurrence, but we would like to repeat a PET scan after 2 more years. So thank you.
Thank you. It was a very well documented case. The next speaker be ready by the time we can have a comment or two. What if you would have done a biopsy and you would have come to know beforehand that it was a leiomyoma? Then how would you manage this case?
So if we had done a biopsy beforehand, then we could have put the patient on regular follow-up. If the size was increasing or it was causing any problems, then we could have actually gone for complete excision. Because it was a benign tumor, only cataract extraction and PCR from superior incision would have been sufficient. But here, because the patient only chose enucleation, she did not want to take any second chance of any treatments or something. We did not have an option. But yes, definitely Actually, we also could not differentiate clinically much between a pigmented ciliary body tumor, melanoma, as and leiomyoma. So even we were more bent towards enucleation.
Quite a bit. Anusi, any take on this? But in choroidal melanoma, we generally avoid taking biopsy.
Yeah.
But it is clinically absolutely the B scan and everything goes in favor. Not in doubtful cases.
Even
Are you
PET
ready
scan,
for
MRI, everything is, there was no differences, ma'am. Even the PET scan said it can be choroidal melanoma, so there was no chance that we could have.
That's fine. You were justified in doing it. That's why I said it was a good document.
Even though we feel bad after seeing the diagnosis, but
No, it's fine.